bariatric educational seminar. We started this a couple of years ago, and the purpose of this meeting is to be able to disseminate information related to bariatric surgery and the medical management of obesity and morbid obesity in such a manner that patients will have a comprehensive understanding of what it is they have to go through prior to actually starting the actual procedure. Also, it's important to get the information that you'll need to be able to make a decision as to whether or not what particular procedure may help you. One surgery may help one person, while it may not be the great option for the other. So this is a very good place to learn some of this information, and that will cut down on a lot of the misconceptions, a lot of the misunderstandings that people may have about obesity, about weight loss surgery, and also about the medical management of morbid obesity. My name is Dr. Keneth Hall. I've been a part of bariatric surgery since probably 2005, and I've been doing them independently since 2012, and I've been a part of several thousand weight loss surgeries over the years. I came in, when I first started, lap band was a big deal. Everyone had a lap band. We used to do about 600 a year, and I spent the rest of my career removing lap bands, because now, as information increased, we realized that lap band for most people was not effective, and the complication rate was just unacceptable. So over the years, we have moved away from the lap band, and we are more focusing on surgeries such as the sleeve gastrectomy, the gastric bypass, which most people are intimately aware of, as well as we also do what you call conversions or revisions. So today, I'm basically going to uncover some of the things that you'll encounter along the way. And in so doing, I'll talk about what is obesity, what is the cost, what are the options as it relates to medical management of obesity and morbid obesity. And there's a new category called supermorbid obesity. How do you manage those if you're in any of those categories? And am I a candidate for medical or surgical? Should I go to medical or should I go to surgical? Which one may be best? Hopefully I'll uncover some of these. But let's start with the basics. What is obesity? In the simplest form, obesity is just the accumulation of fats in the tissues in such a way that it affects the way you function, the way you walk, the way you talk, the way you breathe. That is one of the impacts of obesity. And it's a disease. In 2013, the American Medical Association finally recognized that obesity was a disease. And what we hope that would happen, that people would be more sensitive. People would understand that this is not necessarily a function of the individual. It's not necessarily that they ate too much. It's not necessarily that there's multiple different reasons. So it is in fact a disease. And we finally got them in 2013. It's a huge problem, as you can see. There's a slightly more incidence with women with respect to male, and adolescents increased significantly over the past couple of years. By 2050, over 50% of Americans will be morbidly obese if we continue on this trend. So what are the causes? I did allude to it before, some of which includes genetics, behavior, as well as the environment. Now, some of these you can't change, such as your genetics. You don't get to pick who your parents are. So often you see obesity will run in families. Oftentimes I'll see patients and I ask them about obesity. And on the intake form, they will say their grandparents or their grandmother or their grandfather are also morbidly obese. So we know for a fact that it is carried on in the genes along generational lines. Behavior has to do with your particular contribution. And also I've seen a lot of patients who have sedentary works, people who are bus drivers, etc., who are not as active, and often there's a higher predisposition of obesity with those people. The environment has to do with socioeconomic class, where you live, if there's a lot of fast food around, what school you go to, all these come into play as it relates to the environment. And speaking about the environment, we have learned a couple lessons over the years. We know that as the caloric value increases, and as we take in more, the chances that you become obese is much higher, right? The more you take in calories compared to how much you burn it up, over time, a lot of these people will go on to develop morbid obesity or obesity-related diseases. So many years ago in the 50s, This is what a Big Mac would look like. And now, I mean, this is 2004. Just imagine what it is now. And most people will get a large soda at the same time. So oftentimes one meal may equal 1,500 calories. And if anyone knows how many calories it takes to make a pound, it's approximately 3,500. So if you want to lose 1 pound, you'd have to burn 3,500 calories, right? And that may take hours and hours and hours, maybe over a whole week. With people exercising every day for a week, on average, people will lose about one pound a week if you're doing it really well. Outside of medications, obviously. But how long will it take to eat a Big Mac? Minutes or seconds. So you see, that's part of the problems. Again, portion sizes have increased significantly over the years, and as a consequence of that, it's much more difficult to lose weight. Now, why do we care so much about obesity? Primarily, it's not just the obesity, it's the associated comorbid conditions, such as hypertension, diabetes, liver function, sleep apnea, etc. All of those will significantly reduce your lifestyle. But of all of them, the one that scares me the most is diabetes. Because diabetes is a full system disease. It affects every tissue, every organ of your body, and oftentimes the changes are irreversible. And interestingly enough, bariatric surgery is one of the only means by which people can attain a long-term cure. It's easy. You know, I've seen people lose 50 pounds or 60 pounds and they improve their overall conditioning, but most people can't sustain that, and that is the problem, which is why for many people, bariatric surgery or even medical management may be the only means of getting them out of the obesity paradigm. So these are some of the diseases that we often see in people who are obese. Fatty liver disease, gallbladder problems, infertility is very common. Oftentimes we see patients come in and they have difficulty conceiving, and just doing a simple bariatric procedure or even medical management can make a significant impact on the overall fertility. We know breast cancers, colon cancers, gastric cancers are much more prevalent in people who are morbidly obese, and as such, it's very important for us to try to attain a normal, healthy weight. But you know, saying it is one thing, but actually living it is a whole different thing. People who are obese and morbidly obese and super morbidly obese have many different prejudices and obstacles that they face on a daily basis. Certain things that you may take for granted, such as playing with your loved ones, sitting on a plane, or going through a turnstile, this can be very, very difficult and intimidating. I had a patient, I still remember him, was a pastor. I did him probably about 12, 15 years ago. He was about 600 pounds, and every time he used the slide, he would always tell me that he felt as if he was that patient. And now, the last time I saw him, he was 160 pounds. He has lost all his medical problems, and since then has done very, very well. So we know that obesity surgery works. We also know that medical management, if it's combined properly with lifestyle modification, can work also in some population. And we'll talk a little bit about that. But how do you know if you're obese? How do you know if you're morbidly obese? And how do you know what you may qualify for? So according to the NIH, obesity is defined as, or morbidly obese is defined as a BMI greater than 35, while obesity starts from a BMI of 30 and above. So any one of you can calculate what your BMI is by going online, typing online BMI calculator. You can put your height and your weight, and it would automatically generate a number, and that would correspond exactly, it would line up with this. Now, why do we care so much about BMI? We know from all the studies that we've seen that there's a direct correlation between an increase in BMI and the risk of dying. This basically says that as your BMI increases, the chance that you'll die increases significantly. And I tell most of my patients, I'm at the point now that I'm like an insurance company. You know, a lot of insurance companies use algorithms to tell, and most of them can calculate to the month when most people are going to die because they have so much information about populations, genetics, etc., that they can put some of this information in an algorithm. But after doing it for a while, you can get a sense that some of these people don't have a long life to live if there's no intervention. So this graph is saying as you become morbidly obese, it's going to be much more difficult for you to live a normal, active life. Now, as it relates to costs, how expensive it is. I know, first of all, it's very difficult to subscribe to most of these programs. Some of them you have to keep paying over a period of time. And it's always nice for the first couple of weeks, but after a while it can become very, very expensive. And some people have a hard time committing to those diets. Clothing can be very difficult to come by, also difficult to buy and to find and to source. Oftentimes people have to travel long distances to be able to get some of these services. So all these are the reasons why it's very expensive. In America, it's the management of obesity and obesity related disease is one of the highest as it relates to the economic aspects of management of morbidly obesity. Now, it's good to get a background, but people come in and they'll ask, what are the surgical options? What do you have here at Rome Health in 2024 that can help me? There's also different avenues, and when people come in, we have the information which we can share with them. And typically, patients will come in, they'll get a consultation, and we'll discuss their medical issues, and oftentimes a decision will be made whether or not they will be best served with surgery or medical management. Some people will come in having an understanding or having the feeling that they may best benefit from a gastric bypass because their mom or dad had it, or a sleeve, or some family member or friend had some success with it, while some people will come in and they'll be completely uncertain as to which way to go. That being said, we're well prepared. We're a comprehensive bariatric surgery center, and we can do all levels of bariatric surgery. As such, we're well equipped to be able to advise patients and tell them which way we think they should go. So if you're out there and you're thinking, look, I think I may benefit from either medical management or weight loss surgery, definitely give us a call, and we'll be more than willing to sit down with you to kind of help you go through what the options are. Now, in the past several years, there's been an upsurge of medical management as it relates to morbid obesity. I have been treating obesity with different medications such as phentermine and Topamax for many, many, many years. And most of these medications have been around for a long time. But most of them are limited by side effects. Some of these medications will interact with other medicines. Some of them, the effectiveness go down. Some you can't give because of advances of age. If somebody's too old or too young, it may not be safe, especially if there's cardiovascular risk factors. But in general, this has been around. For some people, a combination of surgery with medicines may be ideal, while some people may only benefit from medical management. In general, people with a BMI of 27 and above for most insurance companies, some, they look for a BMI of 30 and above in order to cover medications. And that fluctuates from policy to policy. They would like to see that, so when you come in, please let us know what you've tried, what you've done. It make a much stronger case when we have to get on the phone and fight with the insurance company to get your coverage. So it shows that you have tried medicine, you've tried fen-phen, you've tried Weight Watchers, whatever it is, come in, let us know, and we'll put that in as part of your chart. As it relates to comorbid conditions, some people with a BMI of 27 and above rather, or even 30 and above, may have heart disease, hypertension, diabetes, etc. And those are what we look for sometimes to help you get the coverage. So definitely, you don't want to be shy about what you have, and we'll definitely try to get you covered. Phentermine I mentioned before, it's been around for a long time. It acts in the brain to help you to decrease satiety, and is also help you with upregulation or increasing your metabolic rate. So I have a lot of people on phentermine, which typically most people recommend keep them on for 3 to 6 months. Some people will keep patients on for a year, but again, this is limited by cardiovascular risk factors. If you have atrial fibrillation or hypertension or some cardiovascular disease, it's probably not a great option for most people. But it's been around for a long time. This is much more effective if you combine this with an active lifestyle, exercise, and healthy eating. But this, for the most part, is one of the first-line oral medications that I put patients on because it's been around for such a long time and it works so well. Saxenda or Saxenda-type medications, okay, Saxenda, Ozempic, Wegovy, they're all in the same category. And how they work, primarily 2 places, centrally, which is in the brain, in the satiety center, to reduce hunger, okay, and they also work on your motility receptors in the small intestine. So what you'll see with some of these people, not only will you have decreased hunger, you'll also have sense of fullness. So initially, especially when starting some of these medications like Ozempic, a lot of people complain of constipation or bloating or nausea. It's very, very common because it actually slows down the movement of stuff through the GI tract. So a lot of people like it. It's been around, and you've seen a lot of people have been using these types of medications over the years, and for sure we also use it as part of our medicines. So these are common medications that you see in weight loss surgery, but the ones I touched on are the most common ones. I also use Topamax also. Topamax has been around for a long time for seizure and headache management, and we have a lot of success with Topamax, but that is limited by certain central nervous system side effects such as forgetfulness, brain fog, as it were. So because of that, we have kind of moved away in some patients. Now, if you go back and look at the NIH report that talks about obesity management, it's very hard to have a discussion without talking about the surgical aspects and the surgical management of morbid obesity. So typically, the algorithm is a person who will combine lifestyle modifications, which includes exercise and dieting, and sometimes if that fails, most people go to their primary care physicians or a specialist, and a lot of people will be started on certain medications either to help their medical problems, such as diabetes, hypertension, etc. Some people will continue on to take medications for weight loss, as I said before, and then for some people, they may directly be a candidate for surgery. And the surgeries that we typically do are the gastric bypass, the sleeve, and revisions. Revisions has to do with taking a gastric bypass, or a gastric bypass patient rather, who have had gastric bypass in the past, but for whatever reason they have had some significant weight regain. We're able to redo the connections, and a lot of those people have gone on to lose a significant amount of weight. So that's a revision. A conversion would be going from one procedure to the next. For example, a lap band to a sleeve, or a sleeve to a gastric bypass. Those are conversions, going from one case to the next. But because we're a comprehensive weight loss center, we can do any of these procedures. Now, as it relates to who qualifies for surgery, typically it's someone with a BMI of 35 and above, and for most insurance companies, they also require some form of comorbid condition, such as hypertension or diabetes. Obviously, you have to be healthy enough to undergo an operation. We often send patients for clearances from pulmonology, cardiology, sometimes neurology, nephrology, endocrinology, etc. Now, it's important that patients don't smoke. We always check to make sure that they're not smoking. Nicotine has a very bad effect on bariatric cases, surgery in general, but primarily bariatric surgery. We have to make sure that patients have been free from substance abuse. For typically the recommended time is about 5 years. So we have seen that a lot of times where cases have to be canceled or postponed or delayed because people have alcoholic history in the past or cocaine or other drug abuse. Now, this slide is just for historic means because people have asked me multiple times over the years about a lap band. I actually took one out today, and I believe I've taken out maybe just about 3 or 4 since I've been here. But the lap band have kind of lost favor over time because it's so artificial, it's so unnatural. But what used to happen was that a band would go around the upper portion of the stomach, and as you put fluid in this port, fluid will go all the way to the band and would restrict the amount of food that one can eat. So that's what, but the problem is over time, this would often migrate, it would slip, it would flip, it would cause damage to the esophagus, heartburn, and a lot of patients didn't do well. So over the past several years, we've just been taking them out. So if anyone listening online, if there is a candidate, if it's a person with a lap band who wants to convert to another procedure, typically we do it either in 2 stages or 1, depending on what's been going on. Sleeve gastrectomy has been around for about 15 or 20 years. It's one of the most commonly done surgeries in the country. Basically, a sleeve is what you call a restrictive procedure. It does limit and restrict the amount of food that you can eat at a time. So basically, this is the entire stomach. And what we do is staple and cut at the same time and remove approximately 70 to 80% of the stomach. and you're only left with a portion, and that's called the sleeve. You know, patients ask me all the time, is the sleeve something you put over the stomach to make it small? No, it's not. We actually just staple and cut at the same time. And that works really, really well for most people. There's no malabsorption, meaning whatever you eat, you are going to absorb. So if you had some milkshakes, you're going to get the whole thing. It's because the entire small intestine is completely intact, compared to a gastric bypass where even if you eat a certain amount of food, only a small percent of that will actually become absorbed. That's why in general, if you look at 100 people undergoing a sleeve gastrectomy and 100 people undergoing gastric bypass, in general, gastric bypass will do a little bit better because they have that second component that prevents all the stuff that you eat from being completely absorbed. But this has been very attractive because it's straightforward. We can actually do this in about 30 minutes. We have a new stapler now that does one fire all the way there, and it literally takes about 3 minutes just to staple across there. So a lot of people like this procedure. If somebody has a lot of cardiac problems, older people with significant COPD, heart failure, this is a great operation because you can get them on and off like this, compared to a gastric bypass that would take a little bit longer. I'm going to show a quick video of a sleeve gastrectomy. I'll talk about what we do so you guys can get a sense of what's going on. So basically this is done laparoscopically or robotically. By that we mean little tiny incisions are placed across the abdomen, just like you see in there. These are called trocars. This is what allows us to do our work through those little tiny openings. These are the instruments that we use to facilitate moving the bowel, moving the intestine, etc. The stomach is what we're focused on for the sleeve. In the sleeve, we only operate on the stomach. See, under normal circumstances, when you eat, food will fill up the entire stomach. So, you know, believe it or not, the stomach can really, really stretch to a large volume. So that shows you essentially how that works. Now, with a sleeve gastrectomy, you're going to remove, as you can see, most of it. So you're left with this small part. But the beauty is that all parts are still there. The upper, the middle, and the distal aspect of the stomach is still there. So this is what a sleeve gastrectomy entails. And it doesn't grow back, but what we're seeing over time is sometimes it can balloon out and get a little bit bigger. And I've had cases where I've had to convert a sleeve gastrectomy to a gastric bypass. I've done probably 1 or 2 since I've been here, maybe even a little bit more. But it's not as common, but that can happen. Okay, and gastric bypass has been around for a long time. Initially, I guess this came out in the, almost like an accident. In the 50s and 60s, people used to do surgery for ulcers, ulcer disease, gastric ulcers that I'm sure you're familiar with. And after a while, they'd realize that a lot of these patients would lose a lot of weight. And over time, there's a surgeon by the name of Mason kind of refined the procedure into what you know today, which is called a Roux-en-Y gastric bypass, just by way of how the connections are made. The advantage is this: overall, the weight loss is faster, and people in general do better, especially in women. I found that even if you have twins, male and female, typically if they both would have a sleeve, in general, guys will do better because they have more testosterone, more muscle mass, a higher basic metabolic rate. So typically guys will do better than women as it relates to a sleeve gastrectomy. What we've seen in gastric bypass, it's about the same. So it kind of negates some of the differences that you see between men and women. So gastric bypass is very good for most people. There are some cases in which I may say, look, it's not safe because of you may need steroids because you have a very bad case of lupus or Crohn's disease or something like that, and it may not be safe. So in some of those patients, we may recommend a sleeve instead. Disadvantage is it takes a little bit longer to do. There's more cutting. a slightly higher risk of complications in the past. Metabolite deficiencies, vitamin deficiencies we sometimes see, but believe me, if you're like most of our patients and you're compliant with your vitamins and minerals, you typically rarely do you see any issues with this surgery at all. I really like it. Initially, this was my second line surgery, but now for the most part, I think we've been doing, right, Stephanie, we've been doing more gastric bypasses. And it's not just us, it's not just me. I think the community is more educated. People have been asking and doing their research. And some people come to me and say, hey, I just want to do it one time. If I only want to do it one time, which one? And if that's the case, I think the gastric bypass is definitely superior and should be one patients consider. Now, I'll show a video of the gastric bypass. It's a little bit more difficult to understand, but I'll show it nonetheless. Same principle. Tiny incisions, very, very similar, almost identical. There's virtually no difference. So people ask me all the time, which one hurts more? Basically the same. Which one keeps you longer? They're basically the same. And pain is not a big issue with this case at all. Patients typically go home the next day. So again, remember, this is the stomach. Gastric bypass uses the stomach as well as the small intestine, okay? Remember the sleeve, we only operate on the upper stomach. With a gastric bypass, we make a cut in the small intestines, and then we're going to bring this up towards this. This is what we call a pouch. This limits the amount that you can eat. It's normally about 3 ounces or so, depending. Okay? And when patients eat, the food will come from here, and it will just travel all the way down undigested into the lower part. Okay? And then your bile from your gallbladder or your pancreas, everything mixes right here, and this is where digestion starts. Digestion actually starts down the bottom. So the gastric bypass is more effective because you have a smaller pouch, and then you have some wasted intestines. So in other words, food will pass through undigested, and because of that, you don't have that weight regain compared to the sleeve gastrectomy. All right, so we'll go. So this just shows you quickly, for people with medical problems, this is very important. If you look at the sleeve and the gastric bypass, for example, I'm just going to go through a couple of them. The one we see a lot is the diabetes. I mean, we can almost always cure diabetes. You know, there's some patients that are much more difficult and more hardy, but for the most part, within a week or so, most people are almost basically completely cured of this problem called diabetes. High cholesterol we see, most people are cured, 97%. Cardiac involvement. I did a patient on a heart transplant list once. I can't forget, she was 34-year-old, and she was on the heart transplant list, and she was just waiting, and they asked us if we would do a gastric bypass. We did a procedure, and she did well. She actually came off the list. So it makes a difference. It tells you the amount of stress that your heart is on when you're morbidly obese. But she did very, very well. So all these conditions get much better after having bariatric surgery. What are the complications? What can go wrong? They're very, very rare because our program, for example, is very protocolized. If you have a BMI of this happens, you have to walk, you have to get up. You know, we're very passionate about what we do, and we want to make sure that we keep our complication rate down really, really low. Bowel obstructions are something you can see. Typically, there are certain guidelines that we tell patients to follow. I've seen cases where patients may want to go faster than what we recommend, and that can cause an obstruction because of the swelling that you have after surgery. So we have diet stages 1, 2, 3, 4, etc. that we expect, but sometimes patients may move before. Sometimes people may get other problems such as gallbladder problems. It's very common. Back in the old days, they used to take your gallbladder out all the time with this surgery, but now it's just rare because everything is done minimally invasively, so it's easy to go back and take your gallbladder in. Many years ago, when people had these giant incisions, it used to be much more difficult. Now, how do I tell my patients to look at the whole paradigm of morbid obesity, obesity-related diseases, and how do they fit in? I believe always try to attain and maintain a healthy weight, but it is a balancing act, right? Calories in, calories out is something that's been around for ages, even though we know that's not the only thing. the only factors at play. But for the most part, it stands true. If you take in more than the energy that you burn, typically you'll have weight gain. And the opposite is true. You burn more than you actually need, you get weight loss. Okay, so for most of our patients, we want them to be here in this area. So surgery allow you to reduce what you take in. And hopefully you'll also exercise on the flip side. So this process will be much faster. Again, typically, lifestyle modification includes diet, physical activity, exercise. I tell all our patients, you know, as it relates to dieting, I'll say this, you know, there's so many different diets, it'll blow your head off. It's just so many different aspects of it. And every day there's a different diet. There's a diet with every doctor on the planet. Every doctor has a diet. The only one that works is the one that you actually follow. The problem is with most of these, people can't maintain, they can't sustain it. So you may do it for 6 months or a year, but typically most people will fall off. What we tell most of our patients, especially post-bariatric patients, is to try to keep your calorie intake from about 1,200 to 1,500 calories, depending on activity. Sometimes a little bit more, it depends on activity. But multiple small meals. Multiple small meals, people have found out over the years, haven't stimulated the pancreatic enzymes as much, so insulin stays low. Insulin is one of those loving hormones. So when you eat a huge meal, the insulin level rises, and it tells the body, hey, store all this stuff as fat. So energy gets stored as fat, so hopefully in the long term, you'll be able to survive. That's the whole premise. So multiple small meals for most people work really well. And there's intermittent fasting that also works. Problem is most people are not compliant with intermittent fasting. And if you don't do it properly, you'll go into starvation and your weight loss will also slow down. Now, once you do all that, you've maxed that out, lifestyle modification, you have tried, or you have a medical problems, you have back issues, you can't exercise, whatever the reason is, you have a strong family history, every person you can think of is morbidly obese, then you can also do pharmacotherapy. Now, there's some people that bypass this and go straight to bariatric surgery. I see people all the time, and some of those people actually need it, because if you wait for all this, sometimes it's, believe me, it may be too late. So, but this is the normal progression, however. So medications like we spoke about before, sometimes for some people they can't do it, they can't tolerate it, insurance won't cover it, and then the pinnacle or the gold standard for weight loss, believe it or not, in 2024 is still bariatric surgery. It's not for everyone, but typically for those who do it, it makes a huge, huge difference. Now, this requires a huge commitment on the part of the surgeon and the team, but most importantly, the patients need to be bought in and understand that it's a very important step and that they should take it very, very seriously. We have one of the highest level of accreditation of any center, so we've done it all. We have an absolutely amazing team that supports me and supports us and supports the institution every single day. You know, we're not like a lot of other programs. We believe in regimen, and we have a different approach to a lot of these bariatric patients. We'll know all our patients by name, by profession, by what they do, and we really kind of get engaged. And we find that approach, a familial approach, is much better. People will relate to you better, and typically the outcomes are much better. Now, considerations, people ask me all the time, what age is too old? I think the oldest I've ever done was probably 87, believe it or not. People ask me, why would you do a weight loss surgery on an 87-year-old? I've done surgery on a 103-year-old. No, not bariatric surgery for the 103-year-old, but the point is, it all depends on your conditioning. That 87-year-old looked at that time, on paper at least, looked better than a lot of other people. And we thought that she was going to live for at least 20 years. So if you're going to live at least 20 years or 10 years, why not improve your quality of life? So age by itself is just a relative contraindication. We have done as young as 14, and that's what I've done in the 80s. Again, you have to be committed as it relates to the procedure. That's going to be a discussion between us when you come in. We'll talk about it, but most people will come in and they'll say, look, I want a sleeve, I want a bypass, or XYZ, because my mom, dad, family member, etc. The expectations is hard to say these days because there's multiple factors, but in general, I would say, outside of this slide, in general, most people will slow down at a year. meaning, well, it will be significantly slowed by a year. Most people will continue to lose for a year. Some people go out to 18 months. But in general, people slow down about a year. That's when they typically get their maximum weight loss, and sometimes the appetite will start coming back at that time. That being said, if you continue to do what you're told and taught, people will do very well. In general, people who have underwent gastric bypass, again, will do a little bit better. You see at 18 months, most of them are still doing very, very well. So what's the next step? Well, the next step is to schedule a consultation with us. We'll talk about whatever it is that needs to be done at that time. We'll talk about what referrals you may need. Many people may need to see a pulmonologist. Some people may need to see a gastroenterologist. We typically do an upper endoscopy to take a look at the stomach to make sure the stomach is okay. Everyone needs a psych evaluation. That was very difficult for us, but recently we have had a really nice relationship with a psych center, so we're able to get patients in. A lot of people will also need sleep study. Some of these can be done at home now. Cardio evaluation. Some of the insurance companies are requiring it, that people see pulmonology, cardiology, etc. So it's not that we want to torture you. Sometimes it's a requirement of the insurance company. And ultimately, once all this stuff is done, you'll do your preoperative testing, which includes huge vial of blood work and x-rays, EKGs, etc. Ultimately, patients do very, very well, and we're very proud of what we've been able to accomplish over the past 2.5 years. Now, why Rome Health? I've been fortunate, as I said, to be a part of multiple different cases over the years, and very complex cases. We were a referral center where I came from, so that was the reason why I was able to do a lot of complicated revisions that a lot of other surgeons don't want to take on. I actually enjoy it, but over the past couple of years, we have gotten more than a fair share, I must say. That being said, it's important because some of these patients do need that help, and sometimes they didn't get that initial attention from the original group or center. So we like to treat everyone with dignity and respect and give them a chance to get a second chance. I'll often get on the phone and I'll fight with insurance companies vigorously to get some of these patients approved, but sometimes they still turn us down because there are tiny clauses in their coverage, etc. But in general, we have a very, very professional, well-regarded staff, and without that, we wouldn't be successful. So our commitment is to get you in the door really quickly within a short period of time. And again, we try to streamline the process over doing it over the past several years to make sure that you guys can get in and out and make sure that you have an excellent outcome. Now, this slide just telling me that I'm almost at the end. These are some famous celebrities who have had bariatric surgery before, whether or not you knew it. It's not just them, okay? They did some surgery. These are some of my patients over the years. This guy, believe it or not, was close to 600 pounds. And I remember it was very scary, this surgery. He was very close to 600 pounds, had a lot of medical problems. And I was concerned that he wasn't going to survive the operation. And that guy today has done well. Last time I saw him, he was probably like 190 something pounds. He works out all the time. He's like the face of Lifetime Fitness in Long Island. So still communicate with these people. I'm very, very excited. I mean, this is him right there. And this picture is about 3 months in, 3 to 5 months in. And this is, I think that's like a year after surgery. So it can be done. It can be done. Patients do very, very well. But again, it's a combination of the practice. And of course, the most important thing is the buy-in of each patient. I'll end on this. I've been always interested in surgery as a kid. And initially, those of you who know me on the outside know I'm very passionate about cosmetic surgery. So all along I was in training, my goal was to become a cosmetic surgeon or plastic surgeon. And during training, I met a guy that would change my life. And I would see him, he ultimately became my mentor. And I would see patients driving from out of state. They would sleep in their car, and they wouldn't let any other surgeon touch them. I'm like, who is this guy? I've never seen anything like this. They would leave. I remember a lady, she drove from North Carolina. She stopped. I only want this particular person. And over the years, I've learned a lot from that particular surgeon, and put a lot of the things that I've learned in practice today. So I have him to thank for my passion. But ultimately, I had switched from that time from plastic surgery to weight loss surgery. But most importantly, I saw the impact that it had. I've never seen a surgery in which you can do one surgery and you have an impact in so many people's lives. One surgery, you operate on a mom or dad, and the kids will start exercising at home. I mean, the entire community will start jogging. There's a spiraling effect in a very positive way, and I've never seen it before. I've never seen it in any other field of surgery, and I've been around surgery for quite some time. So I'm very passionate about this, and it does work. It's just very unfortunate and very sad that bariatric surgery, a simple surgery nowadays, when I say simple, compared to other stuff, because the technology is such that we can do it safely. It's very, very rare that you have an adverse outcome, and it's so underutilized. It's just absolutely amazing. You have something that can change life in a heartbeat. You know, people go get orthopedic surgery like this, a drop of a hat. And part of it is the insurance company. You can get your gallbladder taken out in 2 seconds, but for bariatric surgery, they torture you for 6 months. We've been trying to fight with the American Medical Association to lobby Congress to get some of this stuff to change, because I don't think it's right, because while people are waiting, people are dying, and people are dropping out along the way. So I said it to say that I'm very, very, very proud of the team. I'm very proud of what we've accomplished over the past, was it 2.5 years, Steph, or 3? 3 years. And I just want to say, on behalf of the staff, thank you very much for the hard work that you have done. And I appreciate the input and what you have done to elevate this program. I also like to thank the administration of Rome Health. Chuck, thank you very much for what you have done. We do appreciate you. We couldn't have done half of this stuff without your help. So with that said, anyone has any questions about anything? Questions?
If not, I got a couple online.
Sure, go ahead.
When I read them to you, just repeat so they can hear you on the mic.
Sure, go ahead.
So the first one is, how do I make an appointment to come see you and discuss which options are right for me?
So the question was, how do they make an appointment to come and see us, and how did it? And what's the second part?
And to discuss which options would be right for me.
Okay, so and then they wanted to know how they would discuss, or when they would discuss the options that were best for them. But as I said before, we normally do that at the initial appointment. So when you come in, Steph, what number should they call? What's the number? 315 338 7040. So that's the number that you'll call. Are you able to put it on the screen?
Yep.
That's the number that you'll call to get an appointment. And at that initial appointment is when we'll look at all the factors involved. Just let us know what are the factors at play, and we're normally making a decision at that time as to what procedure will suit you best. And then there have been times that we have changed. I've had people before that said, oh, I want a sleeve. And then I had one last week. She was all about a sleeve, and then last minute she changed her mind. So that's completely fine. But typically we decide on how to proceed the day of the initial consultation. And that's a bilateral conversation. It's not just me saying, hey, you're getting this operation. Next question.
Yep, the next one was, how long do I need to be nicotine free if I'm a smoker? How long do I need to be free from nicotine to have?
That's a very interesting question. We get asked this question all the time. Now, I'm going to answer, but I don't want it to be a situation where, because we've had patients, if we tell them 6 weeks, for example, they'll wait and just for only 6 weeks. Ideally, you want to stop now, or you want to definitely start slowing down and make a conscious effort to stop. And we can help with medications and with treatment and referrals to kind of help you. But typically, the minimum time, 6 weeks. Most people say 6 weeks. And there's several reasons for that. Well, in general, nicotine have a very harmful effect on wound healing. It causes the blood vessels to get small and doesn't carry as much oxygen. And because of that, because bariatric surgery is so high risk in general, the complications are much higher. So you want to stop and get that nicotine out of your system. Minimum time is 6 weeks, but even though that's the case, You want to stop. The sooner you stop, the better it is. Because it's not just the surgery, it's your whole lifestyle that will be affected. And vaping also counts. Stop. This means no tobacco of any sort.
And the last question was, what is considered purposeful exercise? Is it like walking my dog, or what would I have to do?
Anything.
That sounds. What did you say? Anything?
Any exercise is good.
Well, any exercise. Good point. Any exercise is. So the question is, what do we consider purposeful exercise? And we like that word, purposeful. I use it all the time. Now, as the gentleman in the front said, any exercise is good. Yes, but there's some, we can qualify that some. So purposeful exercise is exercising with a purpose, a reason to. So typically walking with the dog is not. Walking with the dog is typically to clear your head. And it's very good. I encourage it. You should walk your dog. You should do all that stuff. It's really good. It's more to relax. But typically, I've seen people walk their dog all the time. They walk and they stop every 2 seconds, and the dog pulls you half the time. So the best way to do it is to do cardiovascular exercises. That's what I'm primarily interested in. So getting your heart rate up for a certain minimum period of time and keeping it that way. For example, a treadmill, even a brisk walk. And according to the American Heart Association, typically, if you can speak, if you're walking and you can speak in a normal voice, then it's not effective enough. So you should be out of breath. And that way we know we get you in that target heart rate, which maybe for some people 160 to 170. Will you get benefit if you were to do it? Absolutely. And you can start at any point. Just remember, you want to end up to a point where you have improved significantly from where you came. But you want to give yourself goals. Like today, for the first week, you want to do a mile, half mile, whatever it is. And you sequentially increase that over time to increase your cardiovascular endurance. So again, purposeful exercise is you having a plan. And not just once a month, something that you want to do on a weekly basis. Again, according to the American Heart Association, you either should do it 1 hour minimum 3 times a week, or half an hour 5 times a week. That's the absolute minimum. And just remember, if you have an iWatch or a phone or something that can track your heart rate, you want to get your heart rate up probably about 150% of where it normally is. So if your heart rate's 100, you probably want to get it a little higher, 150, etc. You want to maintain that for half an hour. Obviously, if it's safe, don't go running a marathon tomorrow morning without talking to your doctor and making sure your heart's okay. But definitely start slow and increase over time.
And actually, I've got another one while you were talking. The question is, what is the percentage of effectiveness you've seen 1 to 2 years after GLP-1 medications?
Well, good question. So the GLP-1 medications are what we spoke about before, right? Which were the Ozempic type medications, semaglutide type medication, Ozempic, Saxenda, Wegovy, etc. We don't have a lot of data on that. Most people, because most of these studies, you have to understand, to get FDA clearance for most of these, you need 1 year. Most medications, they look at 1 year window. So most of these were done with an indication of a 1 year window. That being said, most people, the people who do well with the GLP-1 type medications are the ones who continue to combine it with dieting and exercising. Just taking the medication alone by itself, typically I find that after about 8 months to a year, most people start to have weight regain. Like most medications, the body will kind of get used to it after a while, so the effectiveness will go down. So what I say on people taking those medications in the long term, make sure every time you lose 5 or 10 pounds, you have to increase your cardiovascular activity significantly. So you can't lose 100 pounds or 50 pounds or 20 pounds and still do the same walk, same slow walk you do every day. You have to continuously increase the demand. So people on those medications, I can say them still remaining effective, but those who are effective typically combine with strict dieting, strict exercise protocol. And if I have to look at that and take that into consideration, it's about 60%. That's what I've seen. 60% of people who are continuing to do all this stuff right will do well. Most of these medications will are limited by nausea, vomiting, and severe constipation. And oftentimes when our patients stop is because, number one, besides price, because price is the most significant barrier for most of these medications, because some insurance are still not covering it. No Medicaid or Medicare, and some of the Blue Cross programs are still not covering that medication. So outside of price, one of the biggest obstacles are nausea, vomiting, and constipation. And but for most people, that does get better over time, and we definitely, when we start patients on that, we always offer them Zofran, which is the anti-nausea medication that gets dissolved under their tongue. So people do well in general and are very successful. Good. All right. Again, thank you guys. Thank you very much.